Well, there are a lot of differences, and I'll focus on 3 of those. One is certainly the main reason why we think it's bone sparing. It's an isoelastic cup, is elastic malleolus, is similar to bone. Then it certainly makes a difference when we image after implantation, where we have a problem. And then I just focus some off-label use technical aspects for treating problems of the cup placement. Now, we all know that the stiffer the cup, or we believe the stiffer the cup, the more stress shielding there is. Even with this Morsher cup, which is also a monoblock, we have some stress shielding, as you can see in this time of 9 years in between the implantation and the follow-up. So you see some radification of the trabeculi in some areas, and you have an increase at the cortex, all laterally, can be seen laterally. Now, the significance of weak bone, it may predispose to migration. When you have early mechanical failure, it may facilitate migration of wear particles. There may be problems in revision surgery. These are all theoretical aspects, but in the end, we don't have yet evidence that is true. Or just yesterday, someone mentioned the publication that hints in that direction. The load transfer to the natural hip was investigated by Wittmann and Morsher a while ago and published in 2002. And what you can see is that the load transfer, depending on the weight across the joint, is always in the area of the horseshoe. But there are 3 areas, an anterior, inferior, posterior, inferior, and the superior area where you have an increase of load transfer. This is the natural hip. But we know as soon as we implant the stiff cup, then the load transfer goes across the acetabular rim, and we have some unloading or stress shielding of the cancellous bone behind the cup. There is some indications how fast this occurs. Most studies cover a time period of 1 to 3 years, and they show a decrease of bone mineral density of 8 to 33%, depending where they measure it. And there is, to my knowledge, only one 10-year follow-up of an uncemented metal back that showed a decrease in the first 3 years, and then after that it stays more or less stable. You see that the cancellous bone density, the decrease in the first year, 22%, then 30% up to the 3rd year, and then it remains stable up to 10 years. It depends what you implant. The stiffer the implant, on the left, a chrome alloy shell, titanium shell, PEEK shell, or if you use just polyethylene, you will see that you have more stress transfer in the center of the joint, more close to the natural load transfer in soft shells. So you have if you use highly cross-linked polyethylene, you have highest peak stresses within the acetabulum, not at the rim, and it's distributed over a wider area, as you can see on the very right image of this publication. So overall, we know that acetabular cups, the stiffer they are, the more bone loss you have behind the cup. You always have a mismatch, and the increase of the increase of density of the cortical bone at the periphery, where it's attached to, is about 3.5%, but you have a decrease of the bone behind the cup up to 33%. So our expectation is that with less bone loss with softer cups, and is this true? Well, we have some controversial information. We have this one publication from Scandinavia, where they used the CT BMD measurements, and they showed a decrease over 2 years. But then we have this work from Gary Hooper, which he presented recently at the New Zealand Orthopedic Association meeting, where he did dual energy bone densitometry pre-op at 6, 12, and 24 months post-operatively in 5 regions of interest, so medial, medial superior, and further above the acetabulum. He compared 3 different stiff shells, like all PE cup, which is a Vitamins cup, titanium shell, trabecular metal shell, And he has shown that with the old polycup, it has the least decrease. In some areas, even a slight increase of bone mineral density, mostly superior of the acetabular dome. So that's a randomized study which probably gives the most valuable information currently, but we are still waiting its publication. Now, is this just a theoretical advantage or does it help? I think it does help. This is just an example of a 60-year-old cycler. He did probably 250 kilometers on his bike a week, so very active. He fell on his right side. As you can see on his left, that isn't broken, that he had severe osteopenia behind this acetabulum. Maybe with a softer, with a Vitamins shell, he would not have fractured. But we don't know that, but I think that you're laughing. Don't ask me afterwards. Now, imaging after implantation, we all know that with the metal-backed heavy cups, we always face problems. We have artifacts, we have difficulty to visualize and interpret the soft tissues around the cup. There are metal reduction protocols which are helpful for these situations. But certainly, if we have a full polycup, we almost always have excellent visualization. We have only very little artifacts, depends on the femoral head, if we have a chromium head or a metal head. But as soon as you use ceramic, you won't have this problem. And you can analyze the structures around the cup. You see the interface between the acetabulum, the cup, and the bone. You can see if there's some liquid in the joint. You even see the holes of the cup used at insertion. So it's very helpful. So that's a clear advantage of a monoblock polyethylene cup. So the imaging is definitely easier in monoblock poly cups than to modular cups with a stiff. Now there are also some technical aspects which I just want to a bit off-label use. But this is an example of a 30-year-old female patient with advanced OA on the right hip, where we did a total hip replacement on the left hip. And we do in pre-op planning, we look posterior rim, and when you put those lines on the other side of the hip, then you will see it matches the marking ring of the cup. But that means that probably the cup is a little bit protruding over the anterior rim. And if you do the imaging, you already can see on the lateral cost table view that the cup is a little bit protruding anteriorly. But with the MR imaging, you can see that the psoas is conflicting there and causing a problem. So the solution is, what will you do? Well, literature tells us that you have to do a cup revision, remove the cup. Some people cut the psoas. In this situation, you can proceed differently. This is an hip arthroscopy, a view of the Vitamins cup. You see the titanium particles impressed on the cup, and you can see it, I think on the left side, you see the psoas tendon which drops over the cup. In such a situation, you just can remove the titanium cover to get a smooth surface, and as soon as the psoas rubs or glides over another smooth surface, the pain is gone. We have done this in 6 cases so far, more male patients, rather young. We always do it, we do a positive infiltration of the ilopectoral bursa, so the pain has to go away. If it comes back, then we, with no permanent relief, we'll proceed. And we have 4 that pain-free and 2 that improved, still some remaining pain. One is just 6 weeks out of surgery, so he still may have some pain. But that may be a solution for this problem. And this is, what is that if that acetabulum is too small? And I'm hoping that Mathys is working on that problem a little bit. This is a patient who had a very small acetabulum. In addition to that, the cup was not enough in anteversion and the stem was in retrotorsion. And she had typical symptoms of psoas irritation. Difficult getting into the car. As soon as she lifted her hip, she had severe pain in her groin. So we did a revision of the cup and the stem. unfortunate trochanter was a bit too distal, but she had very soft abductors. But as you can imagine, in this situation, even with this cup with more introversion, we still had a defect anteriorly. How did we solve the problem? And that is certainly an advantage of a soft cup. You just remove part of the titanium cover in the area where the psoas glides, and you may see on the X-ray on the AP hip that there's an area where you can't see the texture of the titanium. That's also a solution you can give to the patient, and it works quite well. What do the registries say comparing to the cups? Well, the New Zealand registry is one of the few that follow our ImpressFit cups and have a very low revision rate per 100 component years, which is around 0.55, which is similar to all the other revisions of other cups, which is about 0.58. So even the registries show at least an equivalent, if not slightly better, results. Thank you.